Let's see. I don't think I have it on the right page, but I'll get it on the right page once I hit the share button here. You're getting a sneak peek at all the information here. All right, folks, welcome. If you wanted to hear the truth about knee pain, you've come to the right place. My name is Troy Vander Molen. I'm a physical therapist. I'll tell you just a little bit about myself in a little bit, but I want to let you know that if you want to interact, I'm happy to do that. There's a chat button, so you've already used it. If you have a question that you want to answer, just hit that chat button, type it out. It comes directly to me. No one else can see it, so there's some anonymity to that. And I'll try to get to those things. We got a lot of people on the workshop tonight, so it might be hard to get to all these, but I promise I will get to them afterwards and get all your questions answered. I'm also going to give you my personal contact information, the emails that you've received after registering. If you reply to those to get information to me, it will eventually get to me. It goes to Cassie, who has done all the marketing for this thing, and she forwards it to my inbox. So you can always get a hold of me that way, but I'll give you my personal contact information to be a resource for you moving forward as well. As I said, my name is Troy. Why would you want to listen to me? Well, let me just give you a really brief background. I've been a physical therapist now for almost 29 years after graduating in the 90s from the University of Iowa. It's a great program, top 2 or 3 in the nation, year in and year out. And I'm happy to have gone there, learned a ton. But I've really learned a lot more over my 20 years as a physical therapist, including what doesn't work. And that's half the battle. And I've gone on and get some advanced education. I've had my doctorate in physical therapy for almost 12 years now. I've been a CEO. That's wrong. I got to update that for over 20 years, probably 22 or 23 years. Our company is based in Iowa. Pella is where I'm sitting right now. That's our headquarters. We have 9 clinics all the way from Ames down to Centerville. We founded the practice 27 years ago already. And we see a lot of people. And the most common reason people come to see us is low back pain. That's another version of a musculoskeletal type of an issue. We're not going to talk about lower back pain tonight. We're going to talk about our second most common musculoskeletal injury or irritation, and that is the knee. Knee and shoulder are kind of tied for number 2 in our clinics. And you're going to hear things that I've learned both at school and through the practical practice over the last 29 years. I also want you to know it's not just me. I'm one of almost, 35 to 40 physical therapists in our practice and a lot of other assistants and movement professionals. We are very strongly focused on what we call 3D movement analysis and performance, 3D maps. And what that means is, in a very small nutshell, it's okay to do stuff on a table, straight leg raises from the back lying position, side lying position. Those kind of things are okay, and they're necessary at times, but life happens between gravity and the ground. And what happens at your knee is impacted by gravity as the foot hits the ground. So our focus is on how do we get that knee to do what it's supposed to do when it's a part of a dynamic movement system, which means it's impacted by a lot of stuff around it. What's happening below the knee at the ankle is really important. What's happening above the knee at the hip is really important as well. And so getting your knee to hinge back and forth, while necessary, is incomplete when it comes to understanding true function. So that's what we're going to look at today, is understanding how that knee moves as a part of a symphony of movement, a dynamic system. Now, you might be thinking, what in the world are we doing here? Is this right for me? Let me tell you about the kind of people that I've helped over the years most commonly. Usually these are people that say, I really don't want to be here. I hoped that it would go away on my own, but it's getting worse. And as it gets worse, it's impacting my life in ways that I'm not comfortable. I want to be able to do some things I can't do anymore. I want to do it with more comfort, with better competence. And people get concerned because if they can't walk well, they feel like, well, the next step is I'm going to be more dependent upon others. So if you're concerned about losing your independence, this is a great place for you. These type of people also can ask some difficult questions, things like, man, what can I do to make this go away? Or is there even a solution? Maybe I need surgery. What's going to happen if I don't make this better? Those are really good questions. And if you found yourself asking those questions, you're in the right place. One of the things we're going to talk about, and I already have, I've alluded to it just a little bit, that the knee is not an independent entity within a vacuum. It's a part of a system. And in your body, your knee is impacted by the things around it. You are too. This is a truth in life. For better or worse, we impact those around us. and we are impacted by those closest to us. And when we hurt and when it progressively worsens, it's harder to be in a good mood. It's harder to treat others well. It's harder to care for our families. And so if those are concerns of you, this is a good place for you to be. Ultimately, I hope that you understand that there are things that might make it feel better, but there are other things that get to the root of the problem. And my goal is to get you to the root of the problem so you can fix that while avoiding high risk procedures and some of the side effects that can come from medicines that we take. Most everyone that comes here is saying, I just want to move better. I want to move more comfortably. If I can be pain free or at least reduce my pain, that would be great. So that's who this workshop is for. We get some people here sometime that they just want that, hey, snap the finger and make it better, the quick fix solution. I just want to, have someone do it for me. It's not really how that works. What we're going to talk about today is this thing that's developed in your knee is likely a cumulative issue. And that means that to get to the root of the problem, it takes a cumulative approach as well. And that means it's not a quick fix. It doesn't necessarily mean it's not simple. It actually is quite simple. A lot of stuff we're going to talk about tonight are very simple concepts, but it's not always easy to have the patience and the fortitude to do the little things over time to make it get better. That's often what it takes. Unfortunately, most of the things that people in our world do, including physical therapists, don't get to the root of the problem. Most of the stuff that we do with musculoskeletal issues simply mask symptoms. Well, I want you to feel better too, but ultimately for you to be well, you have to function better too. And I would like to help you avoid surgery or get benefit out of a surgery you've already had if possible, because surgeries can take damage and clean it out. But I'm hoping that you're willing to ask the question behind the question, why did that damage exist in the first place? And what have I done to prevent or reduce the likelihood that it will come back again in the future? That's the problem with surgery. You can take some of the damage and make it better, but if you don't fix the issue that brought the damage on in the first place, it's likely to return again. So if you do want to learn the root cause, do more than just masking your symptoms and try to find ways that work that are more natural and not requiring surgery or medicinal interventions, this is a great place. Now, I'm going to ask for a little feedback from you right now. I want you to click that chat button and at least answer this very first question. Is there a specific activity that you do that you know is going to make that knee hurt first? So if you could write that down, and then that's the most important question, but the other two bullet points here will tell me not whether this will help you, but it might give us an indication of how much time it's going to take. How bad is the pain on the 1 to 10 scale? And how long have you experienced it? So you don't have to tell me exact days, but tell me, has it been days, weeks, months, or years? Okay. Here's the reality. If you've got 7 or 8 out of 10 pain and you've been dealing with it for 10 years, that's something that is advanced to a level that's probably going to take a little bit more time. Doesn't mean it can't be helped, but it's probably going to take a little bit more time. Okay. If you're dealing with 2 or 3 or 4 out of a 10 pain, it's been around for 2 months or 4 months, that's a different story. We're going to learn about cumulative trauma and how it's insidious, but it is also very predictable. And we can tell where you are on the stages if you're willing to listen just a little bit here. Okay, so here we go. I'm trying to get this little by little. Denise says stairs. Kelly says standing and stairs. We got a couple of people saying stairs already. Years says Jerry. Renee says going downstairs in particular. Aaron, standing for long periods of time, like cooking and food prep. Could be a 4 out of a 10 for years. So that's longer, but not the highest level of pain. Some good, some bad there, Aaron. Christy says, getting up from sitting on the ground with my patients, walking stairs, couple of years. Okay, 6 out of 10 though. So running, says Natalie. She gets a 5 and it's been a couple of months. Okay, so it's a higher level activity in terms of the force, Natalie, with running. And it's only been there a couple of months. I think that's a good sign. That's probably in the earlier stages of cumulative trauma or change with us. So more people are responding, so I appreciate that. You keep responding if you like to. I welcome that. But let me go to this. That first question, what activity makes it worse? It kind of sounds weird, but if you could say, yes, if I do this, it's going to hurt worse, there's some good news in that, because we know that if your pain is reproducible, it's also reducible. If your pain is reproducible with a specific stressor, we know it has at least some, if not a lot, of mechanical influence on it. I'll talk more about that in just a little bit. But look at this bullet point list, okay? It's like I've been reading your mind. Walking, standing, running, squatting, stair climbing, working, housework, yard work. Many of those were already mentioned in the bullet points that you guys listed a little bit ago. And that's because it's a weight bearing joint. So I can predict. These are the things I hear all the time. When I do specific kinds of weight bearing, loading on that knee joint, I'm going to feel it. Okay. That's what an achy musculoskeletal problem at the knee is going to do. But I want to encourage you. It's frustrating to say, if I do that, it's going to hurt. I wish I didn't experience that. I want to be able to do that more comfortably. Yes, that's all true. But if there's something that makes it worse, we know that it's mechanical, and there's hope in mechanical issues. So let me tell you a story. I think this is a good time to tell you a story. You've all seen assembly lines in a manufacturing setting, right? Let's pretend we've got an assembly line and a product, a gadget's coming through, and there are three people side by side that have to do a little bit. One guy, person A does something, person B does something, person C does something. They share the work, it gets sent off. What would happen if person B says, you know what? I don't feel like working today. I don't feel like working this week, this month. The work's got to get done. And if person B's not doing the work, who suffers as a result of that? It's not person B. Person B's taking a break, an extended break. But the people that have to pick up the slack, person A and person C, the people directly next to person B, are probably the ones that are going to accept greater load, take on more stress, do more than what they were designed to do potentially. This is what happens in the human body. The thing that hurts is usually not the thing with the problem, but it's influenced by some kind of a mechanical dysfunction elsewhere. Some neighbor that's supposed to be a friendly neighbor isn't doing what it's supposed to do. So if I go to person A and person C and say, boy, you look stressed. You need a shoulder rub. Can I get you some ibuprofen? They might say, well, you know what? That would help in the short term, but person B is the problem. That's what you got to fix. This is what we're trying to do in the human body all the time. We don't want to know what hurts, but you have to ask the question behind the question. Why is it hurting? Is there a dysfunction elsewhere? If so, we know that there's a mechanical stressor that we need to find a way to reduce. That is the goal with what we're going to talk about. Really, what we're talking about is trauma. Human body experiences trauma. Now, when you think of the word trauma, if you're honest, the first thing that most people think about when they hear the word trauma is something major. A motor vehicle accident, a fall from a height, a fractured bone. Yes, all traumatic incidents, all things that might require physical therapy, sure. And we see those things in our clinic. But the most common types of trauma that we see in the clinic are not those types. The type I just described at the start, the sudden onset stuff, this is acute trauma, and it looks like this. Tissue damage is immediate due to a major stressor. And then when that stressor is eliminated, the body goes through a healing process. And because we are living organisms, as that tissue heals, we get closer and closer to reaching the symptom threshold. And once it gets below the symptom threshold, we're feeling and functioning pretty well again. There's still stuff going on, but we're below that symptom threshold. It's healed enough for us to do our jobs pretty well, right? That's acute trauma, sudden tissue damage from one incident. And when the incident or the stressor is eliminated, we have a natural healing process. These kind of acute traumas are actually made to get better over time because there's not a cumulative nature to them. Most of the things in our clinic, though, most of the things in life are not acute. They are cumulative, and this looks different. It's only taken a few seconds to draw this next arrow. But that few seconds might be weeks, months, or years for individuals. And if you look at the start of that line, it's below the symptom threshold. There are things happening we're not even aware of yet. And then once we cross the symptom threshold, we become aware of something. But at the start, what we sense is more minor. People will tell me at this early stage, I don't feel as good as I used to be. It's just a little bit of discomfort. It's not horrible. I'm going to be fine. It's not that big of a deal. And people, that's what people do. They make excuses. They rationalize it. They don't want to be squeaky wheels. It's not that big of a deal. That is human nature. But if we continue to expose ourselves to the same stressors and don't make a change, with repeated exposure, we're going to have changes occur. And we'll talk a little bit about exactly what that looks like. But let me kind of talk about this bucket analogy first. As I said a little bit ago, cumulative trauma is slow and insidious, but it's pretty predictable. I am 53 years old. I've been a physical therapist for more than half of my life. And I can tell you that being a physical therapist is not physically demanding. It's not like, I grew up on a farm, lots of physical labor on the farm, right? It's not at all like that. But I am aging, and we know that bodies don't last forever, right? And so at the end of the week, now, more than half of my life as a physical therapist, I'm more tired than I used to be when I was 25 years old as a physical therapist. That's the reality. Our bodies change. And the analogy is we're catching water in our buckets. And when we get a little water in the bucket, the first thing we notice is fatigue, right? We're not spring chickens. We know the body doesn't last forever. That's normal. We just keep going. We try to do life. We keep catching more water. And the next step is, for most people, is eventually we start to experience something beyond just a little tiredness and fatigue. We're experiencing discomfort. And the two words in my mind that are most associated with discomfort are stiffness and soreness. It's not horrible, not at the start anyway. It's just there. We know it's beyond fatigue. It takes a little bit longer to get our body warmed up, or if we do something that we're not accustomed to, we need to recover a little bit longer. I get people that will say, you know what, I'm tired at the end of my work week, but when the weekend comes, I recover nicely. That end of the weekend, I'm feeling pretty good. And then the next week starts again, and it all starts up again. But all too often at this stage, people are still saying, you know what, that's normal. I'm not that spring chicken anymore. And so we catch more water in our bucket. And eventually, for many people, it gets beyond stiffness and soreness and eventually becomes painful. It's a different level. The severity of the symptom at pain level is more substantial than discomfort. In fact, discomfort might be 1 or 2 or 3 on the pain scale, really possibly. But I know some of you who said you're having 5, 6, 7s, and 8s. You're not calling it discomfort anymore. It's more significant, and we got to take care of this because pretty soon we got a spill happening. We're nearing the top of our bucket, and my goal is for you to get to the end of your working career and have more bucket than water. Okay, can we find a way to open the valve and let water out? Can we build your bucket? How can we take the stress off of that particular tissue? That's the goal. That's the question we need to ask, knowing that the thing that's hurting, the bucket that's been filled, is simply catching water. Is there a way we can slow the water, take the stress away, reduce the cumulative exposure of stress to that tissue? That's a good question. But as we travel this path, the cumulative trauma pathway, the things that we are going to notice becoming more significant are the frequency of the symptom, the intensity of the symptom, and the duration of the symptom. See my screen here? If you look really closely, this is an old set of railroad tracks, but it's not so old that the train isn't running. If you look closely, around the corner on the horizon, there is a train. And maybe a minute or two before this picture, you wouldn't even see that train. But the person standing in the middle of the tracks might start to notice a little something, maybe just a little rattle, maybe a faint whistle in the distance. The train is given a little warning, but it's not too bad. But the closer that train gets to you, there is a greater sense of urgency. There's more evidence of pending doom. The frequency, intensity, and duration of those symptoms and signs, the whistle, the vibration, the sound and noise, all that grows. That is the cumulative trauma pathway. And the reality is we're not just talking about your knee. We're talking about overall health. Because when people hurt, particularly in weight-bearing joints, they move less. And movement is the key to long-term health. When we move less, less quality of movement, less quantity of movement, our general health status suffers. I believe the statistic is in America, we spend 83% of our healthcare dollars on 6 things. Okay. Number 1, easily the most costly. In fact, number 1 is more costly than 2 and 3 put together. Musculoskeletal issues. That's the number 1 healthcare spend in America by a long shot. Number 2 is heart disease. Number 3 is diabetes. I think number 4 is cancer. And 5 and 6 are obesity and depression. Those top six, five of them, with the exception mostly of cancer, musculoskeletal issues, heart disease, diabetes, obesity, and depression are all impacted for better or worse by the quality and quantity of our movement. So your knee issue puts you at risk for comfort and performance related issues, but it also puts you at greater risk for heart disease, diabetes, obesity, and depression because movement is critical to maximizing your health. So by implementing what we're talking about here, it's good for your knee, but it's good for your overall health. And I want you to have fewer doctor visits and fewer medication prescriptions, fewer surgeries. I've alluded to this a little bit already, but I think the single greatest problem that people make is they make excuses for what they're experiencing, which leads them to ignore the first sign of a problem. That's the typical response. I'm sitting in a home, at least that part of the home is 110 years old. The part I'm in is a newer part of the home. It was built in the 90s. When we moved here 10 years ago, the house was 100 years old, and we had our insurance company come, and the adjuster said, "Yeah, we'll cover you. That's good, except not that roof. Those shingles are old. They need to be replaced. Call us when you got them replaced. We'll add it to your plan." And I just bought this house, and I looked at the size of the roof and the significance of the problem. I looked at the ceiling or the roof, ceiling on the inside of my house. I'm like, I don't see any evidence of issues. I think I'll ignore that problem because it's going to be costly to fix it right now, and maybe I don't need to do that. Now, I'm not going to lie to you. I was rolling the dice. It didn't bite me, but I was gambling. If I waited too long to fix that roof, eventually there was going to be cracks that developed and um, uh, moisture that got into this thing. There would be more expensive problems to deal with. But I did like most people do. I avoided that problem by ignoring it for a little while. Now, you're not in the ignoring phase anymore. You're here tonight. But I do want to apologize because Western medicine is really good at number two. In fact, if you look online, what do I do for my knee pain? There's all kinds of people that want to take your money with the quick fixes, the simple solutions. But most of the solutions that we do at this stage do not fix the problem. They don't get to the root of the problem. They just simply mask or alter your symptom response. So the three most common musculoskeletal treatments as a first response are medications, injections, and surgeries, none of which get to the root of the problem. So my challenge to you tonight is let's get to the root of the problem. If we can go to the root, that we can prevent this weed from growing up again and again and again. That's the only way to solve it. And so I'm going to let a little cat out of the bag here. You are here tonight. You're giving me almost an hour of your time. I'm not paying you anything, but your time is valuable. So I appreciate that. You're going to learn lots of good stuff tonight. You're going to nod your head. You're going to say that makes total sense. But at the end, you're going to say, okay, I know what could cause it, but I don't know what my issue is. And so in order to solve the problem, to find and fix the root of the problem, there does need to be a little deeper analysis of you. And so I'm going to offer you something for being here tonight, and I'll tell you more about that later. Let's first talk about, I think, the most important critical key point of tonight. It kind of sounds logical, right? But most of these musculoskeletal issues we treat as medical problems, okay? And in my training even, I learned it this way. I've had to relearn it or unlearn it a little bit. I'm here to say tonight that most of these issues are not medical at all. These are mechanical issues. So let me give you my second analogy of the night. Pretend it is a perfect spring weekend and you've got a convertible and you want to go out driving. And so you're out on the open road, the hair's flowing through, or the wind's flowing through your hair. You couldn't have a better day. You're loving your life. And then suddenly a light shows up on your dashboard. What do you do? Honestly, what do you do? I'll admit it. I would do this. I'd say, that darn light, it's not reliable. I don't see any other evidence of a problem. I'm going to keep going, right? Raise your hand if you're with me. I've done that many a time. Stupid sensors on these cars, they're not reliable. Okay, so if you do that, you're with me, right? But let's say a few more miles down the road, I start to hear a rattle and it vibrates and I'm smelling something, maybe seeing a little smoke from under the hood. That's a problem. I know better at that point. I'm going to pull off on the side of the road as quickly as I possibly can. But what if I did this? What if I pop the hood, but also pop the trunk? And I open up my door and I walk to the back because I know in my trunk I've got this thick old blanket. And I grab that blanket and slam the trunk closed and walk to the front. And I throw that blanket over the engine compartment and I force the hood down, snap it down, and then I go back into my car and I get in the glove box because I know I got some duct tape there. I'm going to put a little duct tape over that light on the dash. Now I'm not seeing any evidence. I can't hear it. I can't smell it. I'm going to take off. Problem solved, right? No, that's not it. You don't lift up your pant leg and say, hey, look at that. My ibuprofen dial is low. If I just take some ibuprofen, I'm going to be better again. You cannot treat a mechanical issue with a chemistry solution. That might make you feel better temporarily, but it's not fixing the problem. Yet in America, that's the way we're trained, right? If I have an inflamed joint, well, I better take an anti-inflammatory. Anti-inflammatories will make the inflammation go away and make you feel better. Yes. But the question behind the question is, why is it there? And another good question that maybe is not quite as obvious is inflammation a good or a bad thing? In some cases, with mechanical issues, inflammation is actually a good thing. So I would challenge you by this. So saying, don't think medically, think mechanically. These are movement issues that need movement solutions from movement experts. That's what we're offering. So this inflammation thing, I'm not going to get deep in the weeds with this either, but I want you to understand that when we experience some kind of tissue damage, there is a natural response that the body will do to heal that issue. And phase 2, from about day 3 to the end of week 3, this is the inflammation stage. And during the inflammation stage, when a tissue gets irritated and injured, this is the body preparing for the development and growth of vasculature. Blood vessels that bring nutrients to that tissue. And if we allow that process to occur, it will proliferate and eventually mature. And you are left with a tissue that has this network of vascular pathways that bring the nutrients that tissue needs to be healthy. Heart attacks occur because a blood vessel that feeds the muscle, the heart, gets blocked. And if that muscle doesn't get what it needs, it's not going to be good for the heart. The heart is a critical part of our body, right? Much more critical than our knee, but it's still a part of our body that requires nutrients to function in a healthy way. And so we are kind of conditioned in America to quickly take an anti-inflammatory to feel better, when I think we got to be thinking about, what can I do to make sure this tissue heals? Okay. All right, hold on just a second. Sorry, that's what happens on live television when your 130-pound dog wants to go outside. Let's get back on track here. One of my favorite authors of all time is C.S. Lewis, and he's written a lot of stuff. He's been gone for a long time. Most of his stuff was written, I think, in the 40s and into the 50s. The quote that I've got here comes from an essay he wrote during World War II. And the quote is this. This is a summary of it. The magic is not in the medicine. It's in the patient's body. Effective treatment, what the treatment does, if it's effective, is it will either stimulate nature's functions or it will remove a hindrance. So think about that in the context of inflammation. If we take an anti-inflammatory, is it stimulating nature's function? No, nature's function is to inflame. We are stopping nature's function. We are not removing a hindrance, we're actually creating a hindrance. The body is designed to heal itself, and inflammation is a natural phase of healing. And so I would tell you that the enemy is not inflammation, not with mechanical joint related issues. Now, there are healthy habits that can influence the general inflammatory responses in our body. Those things we do need to take into consideration. I will touch on those just a little bit. But we're talking about something that's mechanical. When you say, I hurt worse when I put my foot on the ground, when I'm going up and down steps, when I'm squatting, when I'm running, there's something mechanical going on there. Okay, and we need to do that which stimulates nature's natural functions or removes a hindrance. So as we go into the main part of tonight's talk, I want you to hear the story about Vicky. Vicky was an actual client of mine. This is not a picture of her, but it looks a lot like her. When I worked with her, and this has been 6 or 7 years ago. Very active lady. She was 61 at the time. She'd been dealing with progressive knee issues for over a year, 2 years, I think, if I remember right. She described it as a deep ache, and it was more on the outside of a knee that it hurt. And she said, if I sit down and rest, it feels fine, but when I get up, it's achy. And if I walk too much, it gets sore and sore and sore. And she loved to walk. She walked around the reservoir once, sometimes twice a day. It was a social and a physical and a spiritual experience for her. And it bothered her that she could no longer do that. But she came to the realization, I can't keep doing that. It's getting worse and worse. And she did everything that most people do. The traditional path is, doctor, I'm hurting. What can I do? Well, here's some medications. We'll give you some anti-inflammatories. That'll knock that down. You'll feel better. Okay. It did for a little while. But when she stopped, it got worse again. So she was sent to a specialist. And the specialist said, well, maybe we got to get that information directly in the joint. So she got a cortisone injection. And again, felt good for a little while, but it didn't last because it was not getting to the root of the problem. It was masking the symptoms. So despite all these interventions and traditional responses, her frequency, intensity, and duration of pain was getting worse and worse and worse. She ended up having an MRI, and they said, yeah, you probably should consider having a total joint replacement. And she came to me saying, I want to do this yet. Is there anything we can do? And I'm not going to read all these words, but I'll say this. I had been around long enough to know that that knee was experiencing stress. And I said, we got to figure out why that knee is experiencing stress. In her situation, it wasn't a knee problem. The knee was suffering. The knee was experiencing stress. There was certainly an inflammatory response, and it was understandable I was hurting. And she even had arthritic evidence of changing in her joint space. Okay. But the reason that joint was experiencing stress was because of another area. Her hip was the primary problem. And until we found and worked on fixing that hip related issue, her knee was just at the mercy of what the dynamic system of movement was doing to her when she existed between gravity and the ground. And she worked at it. She did what she was supposed to. It took a couple months. It wasn't immediate, and there was some ups and downs in the whole process. But by the end, she was walking again with her friends and said, I'm 95% better. She wasn't pain free. She had some discomfort from time to time, but she had learned how to take the stress off the tissue. And the tissue said, thank you. Just like person A and person C in my manufacturing environment example, once we got person B moving again. So let's talk first about the most common types of knee pain. As we do that, let's just look at the structure of the knee. We're looking just at the bone and cartilage here. So your knee joint's a huge joint, major weight-bearing joint. It is a hinge joint. So we think of it as flexing and extending. On the front of the knee is the kneecap, that's known as the patella. And of course, down below the knee joint are two bones. The primary part of the knee joint is the tibia as it meets to the femur. And the femur is the hugest, largest bone in the human body. That other bone to the outside of the lower leg is the fibula. So we know, since the kneecap is facing us and the fibula is out here, that this is the front view of the right knee. Okay. Now you're seeing also in here two different types of cartilage. You've got your meniscus. That's like discs of cartilage. This is your lateral meniscus, your medial meniscus. That's the bones sit upon that, and it helps guide and protect and stabilize and cushion movement stresses. There's also, what you don't see on here are ligaments and tendons and connective tissues, and that creates a buoyancy effect. And inside that capsule that develops around this knee joint, which has been stripped away to see these bones and the cartilage, are fluids, mostly made up of water. So by the way, not hydrating yourself properly has really bad on long-term joint health. That cartilage can wear away, and it certainly does. I'll show you pictures of that in a little bit. There's also cartilage here that lines the bone. It's lining the undersurface of the kneecap itself. This is called articular cartilage. It's directly on that bone. Now, your knee is like every other part of your body in the sense that it is designed to move three-dimensionally. And I said it's a hinge joint, right? So we think of it as being a flexor and an extender, and that's true. Movement in that sagittal plane is about 140 degrees. That's pretty significant. The knee can side bend a little bit, okay? Not a lot, but 10 to 17 degrees combined between internal and external, or inward and outward side bending. And then there's also a little bit of twist or transverse plane rotation, about 5 degrees. And I want you to understand that those joints are made to be stressed. We are designed to take on loads, right? But if we are taxing that joint beyond its design specifications over time, cumulatively, little by little, because of dysfunctional movement, we create frictions and tensions, and that can lead to an inflammatory response, which sensitizes nerve endings, which send a pain signal to the brain. The brain says that hurts. Okay. That's what happens. Every body part has to move three-dimensionally. What happens when we stress that tissue more than it was designed to be stressed? That's a really good question. Now, let's talk about the three types of knee pain. We're going to talk about arthritis. We're going to talk about meniscus injuries. And we're going to talk about patellofemoral pain, PFP. Okay. The interesting thing about these knee issues is they can kind of be related to each other. In fact, osteoarthritis also has associated with it changes to the meniscus. So it's not like you have one or the other. You could have a combination of them. I also want you to understand when we talk about types of knee pain, I'm just describing it. I'm giving it a diagnosis. We're not at all talking about causes yet. One particular cause can cause osteoarthritis in one person, meniscal injury in another, and patellofemoral pain in yet another person. All right, so let's look at this now. We see on this one, pretty sure this is a posterior view because you can see kind of in the depth of the distance the patella on the back side. This will be a left knee posterior view because we see the fibula towards the outside here. So therefore, we're seeing in this bigger side a narrower joint space. And we got a lot more joint space on the lateral side, the outside of that knee. So you could look at this x-ray, which just shows bone, doesn't show any soft tissue, doesn't show the meniscus and cartilage particularly, it's just showing the relationship of bone on to bone. And we can see on here that we probably have a loss of some meniscal tissue on the medial joint space right there. And oftentimes you're going to see the development of bone spurs or osteophytes. People are told they have bone on bone often as this develops. I think it's important for you to understand that when meniscus starts to wear out, that meniscus is actually aneural. It has no nerve endings. So meniscus that has damage is not the source of pain. It might be evidence of a problem and a mechanical issue that's at play, but it itself is not the source of pain. So getting rid of that tissue doesn't necessarily solve anything. People that have this kind of an issue, osteoarthritis of the knee, will describe deep aches and throbbing that's well within the knee. And it almost always is worse with weight-bearing activities and can be somewhat better when we take the weight off it. I want you to understand this, though. If you are age 63 or older and have no knee pain, you're very likely to still have osteoarthritis. Okay, 76% of people age 63 and above, age 63 and above would have MRI evidence of osteoarthritis. Only 13% of them would have pain. So it's more common to have osteoarthritis and have no pain than it is to have osteoarthritis and be experiencing pain. And that's not just true in the knee either. I'll show you that otherwise. This is just an artist's rendering. On the left is a very, very healthy, clean, probably a very young person. Okay, so you see great articular cartilage, healthy meniscus, normal joint space. And then the artist says, hey, I'm going to make this look as scary as possible. And you can see cartilage loss causing fissures in the articular cartilage, spurring on the bone. That's a really horrible looking joint, and most of them are not nearly that bad. So, but these changes that occur are natural changes that occur with age. There's normal wrinkles on the skin. And we know that people that have them don't necessarily have pain. So my encouragement is do not treat pathologies, treat causes. So one of the few good things about COVID is that we learned what asymptomatic means. This is evidence of arthritic changes in people that have no knee pain, no hip pain, no back pain, no neck pain, no shoulder pain, no foot pain. They have, as we age, growing levels of funny findings on an MRI. So pathology does not equate to pain. Don't treat pathologies. Ask the question, why am I experiencing the pain? And recognize it is likely a mechanical issue. And just briefly, I want to say, if you've been told, and there's probably, if we have 40 people on this, probably half of you have been told, I've got bone on bone. Okay, it's a really common phrase. I would tell you that is at the very least a significant exaggeration. There's probably a loss of joint height. If you truly have bone on bone, you got mechanical wedging. There's going to be a mechanical block. The knee's not going to move at all. And then think about what would happen if you truly had bone on bone. Because when we land, we strike our heel, you multiply your body weight by 2 to 3 times to determine what kind of forces act upon the knee joint. If those bones were in contact with each other, it only takes the femur 800 pounds of pressure to break. So if you weigh 250 pounds and you put a heavy load on that thing, walk pretty heavily, you'd be in danger of fracturing that thing immediately. Now, with cumulative trauma, it would take a longer time, but anyway, it is really, really, really uncommon for there to be any femur bone fragmenting. So don't be concerned. Lots of times people in the medical field use phrases, they don't intend to be scary, but you've heard of the placebo effect. If you suggest something, it might make you better. And that's true. That can happen, and that's not a bad thing. But there's something also called the nocebo effect, and that has the opposite effect. When you say something and it has a negative impact on people, our brains are exceptionally powerful. When we hear bone on bone, we think we're damaged goods, that we're not resilient. We got major problems. I'm going to tell you that what you have as bone on bone is something that a lot of people walking around and have very little knee pain also are experiencing. Again, don't treat pathologies, treat the cause. Let's look at the meniscus itself. This is not articular cartilage. Remember, articular cartilage is directly lining the bone. If you see the traditional dog bone, right? The rounded ends of this long bone, that's the articular cartilage. But the discs in between, in this case, the lateral meniscus, the medial meniscus, are different types of cartilage. And there can be tearing of the meniscus. But true meniscus injuries are a young person's problem. And remember, cartilage doesn't have any symptoms, so you're not going to feel that change. Now, if you are young, if you have a more sudden onset of knee pain, and then that knee starts to catch or lock in place, you might have a bucket handle tear and that thing's getting wedged in there. In that case, knee surgery could very well be necessary for you to get that wedge out of there. Okay. And that, when that happens, causes sharp pain deep within the knee as well. However, most of these cartilage changes are cumulative. It's not the result of one incident of stress. It's little stresses over time. There's tons of people walking around that feel pretty darn well that would have evidence of this. So again, meniscus injuries are exceptionally common, and the British Medical Journal, British Journal of Medical Medicine, I think is what it's called, did a meta-analysis, which is basically we're going to look at all the research that exists on arthritic surgeries, arthroscopic surgeries for arthritic knees. And they basically found that there was very little difference between the outcomes with surgery or without surgery. In fact, there was another surgery where they did a sham, or another study where they did a sham surgery. So I found they had people with knee pain that had findings on an MRI that showed meniscal injuries. Half of them, they introduced a scope and they cleaned it out. The other half, they introduced a scope and they didn't clean it out. And they found outcomes 6 to 12 months later were no different between the two groups. So the evidence for success with this is not very good. And the British Journal of Medicine at this point says we're not even recommending these surgeries to be done. So again, I'm giving you this information to give you hope. If you find and fix the movement issue, oftentimes that's much more successful than doing a surgery on that thing. Now, why in the world do I have a train on here again when I'm talking about patellofemoral pain? Now, patellofemoral pain is the impact of this pain, patella riding on your knee region, on the femur, and so forth. I call the patella, the kneecap, a dumb bone. Okay. A car can turn and go where it wants to. A train cannot. A train's only going to go where the tracks tell it to go. Your kneecap can only go where the tracks tell it to go. And the tracks are determined by that knee's position, which you probably will not be surprised to hear is determined by the closest neighbors. The hip above it, the ankle, and the foot below it. So people that have patellofemoral issues certainly need to fix movement-related issues, dysfunctions at the closest neighbors. These patellofemoral issues are usually undetectable on diagnostic testing. It's a pretty common cumulative trauma issue. People will say it hurts near the front of my knee, just behind the kneecap. It'll make sounds there, funky sounds. Usually stair climbing, step ladder climbing, curb climbing is uncomfortable with that. And because of the tracking mechanism, it creates a friction response, which leads to inflammation and pain. And guess what? You can take an anti-inflammatory, and it'll feel better for a while, but if you haven't taken the mechanical stress away, it's probably just a symptom reducer that is temporary. It's altering and masking the symptom, not fixing the problem. We got to figure out how to take the physical mechanical stress off that tissue. So let's talk about causes now. A little bit ago, I talked about how the knee is a three-dimensional joint. A lot of flexion and extension, little side bending left and right, and some twisting. Okay, every body part has to have this balance between mobility and stability in three planes. When you get too much mobility and not enough stability, that's dysfunctional. Not good. It's not going to be a healthy joint, and it will likely lead to compensations, which create repeated stress that can have an impact cumulatively on a different joint because it's operating outside of its design specifications. On the other side of it, there are some joints that are way too stable and not mobile enough, problematic as well. We want this balance between mobility and stability. Funny word I like to call most stability. Kind of works, right? And so I tell the story of Goldilocks quite a lot, right? Goldilocks didn't want the hard bed or the soft bed. She wanted the just right bed. She didn't want the hot porridge or the cold porridge. She wanted the porridge to be just right. For your knee to function well, it and its surrounding neighbors need to have a balance between mobility and stability, just right. And when each part does what it was designed to do more fully, less compensation occurs, fewer compensations occur. Okay. And so you're not going to be surprised at all at this point to understand that the most common culprits, the true causes of knee pain, are dysfunctional movements at neighboring joints, the hip above, the ankle and foot below. We're also going to talk about your mid to upper back, the thoracic spine region too. So your hip, remember, too much movement's not a good idea. Too little movement is not a good idea. We need a balance between mobility and stability. Most stability. Some people have overly stiff hips. When the stiff hip doesn't move, something else has to move, and the foot will respond, and the knee will respond, and that increases mobility demands on other parts of the kinetic chain. Your knee is one of those things. The closest neighbors to your hip, below is the knee and above is your lower back. So if you have a history of knee and lower back issues, it's really likely that your hip is a dysfunctional component that needs to be assessed and given solutions for. Okay. And some people have overly mobile hips. This was Vicky's issue. She had some weakness in one of her hips, and every time her foot landed because her hip didn't stabilize, that knee fell inward over and over again. And so that was putting loading stress on the outside of her knee. And guess what? That knee was starting to wear out. She had been told she had bone on bone. And, you could do a surgery on that thing, but if you didn't change the way that hip functions, giving it more stability, taking away some of its dynamic mobility, the movement stress was going to continue to act upon the neighboring joints. And she had back symptoms as well over the course of time. So we found it helped her fix the hip issue. And when she did that, she took stress off the knee. And like person A and person C, once we got person B moving, they're like, thank God, I don't have to do all that anymore. That's how we fix it. Now let's talk about the hip. Think about how we function today compared to how people functioned a couple generations ago. We're sitting in vehicles, we're sitting behind desks at computers, our hips are flexed a lot. And what we're looking at here are your hip flexors. They're called the iliopsoas. It's a combination of a muscle that connects to your pelvis, the iliacus, and one, the psoas, that goes all the way up to the lumbar spine, and it connects to the femur just across the hip joint. So if we're shortening those muscles by flexing the hips all day, those muscles get tight because tissues become the positions that we put them in. And when we stand up, eventually, it's going to pull on its origin and insertion. In some cases, that's going to pull the lumbar spine forward, putting different stresses on the low back. So low back issues are influenced by appropriate mobility of the hip and the hip flexors. Or it could change stress on what's happening at the segment below, at the knee itself too. So we have to find and fix that hip dysfunction. People that have bow-legged or knock knees have uneven forces. And this is a bit of an exaggeration. You're kind of seeing extremes here, but helping the hip move so it looks more normal in its alignment will balance the loading stresses on the knee, leading to a reduction in the development of osteoarthritic changes and a balance of forces on that knee, whether or not it's a perfectly looking knee. What about the ankle and the foot? That is the closest neighbor below your knee as well. Well, the same thing. If it's overly stiff, particularly at the heel, something's going to have to compensate. That motion's going to go up the kinetic chain. Your knee is the first thing that responds to that. An overly mobile heel, if your arch drops significantly, okay, something's going to compensate. More motion at the knee as a result of that. And the knee will experience mechanical stressors, potentially beyond its design specifications, which a week or a month isn't that big of a deal, but day in and day out for months and years can create problems, cumulative problems as water fills that bucket. Okay. So again, you can see the influence of foot position on alignment, and you can imagine what influence that has on all the joints up the kinetic chain from the knees to the hips. It's not just a knee that gets extra stress. These kind of foot issues can cause problems all the way up the chain into the lower back as well. I will tell you from my experience, most of the people that have these um, uh, arches that drop, it's really the origin is a poor hip stability, poor hip strength. So a lot of what we do for knees is making sure the hip can do what the hip's designed to do, because that helps the knee and the ankle to experience less mechanical stress over time. The thoracic spine. If you can, I want you to, well, let's first do this. I want you to slouch. Okay, you don't hear PT say this much, but just slouch. Okay, when you flex that spine, stay slouched and just try to rotate them. Hard to do, isn't it? Now, if you sit up tall and you try to rotate, suddenly you start to feel like you have better freedom of movement. But a lot of people over time, gravity takes them into position. And we get tightnesses and weaknesses that develop as a result of that, cumulatively, right? And when our thoracic spine cannot rotate anymore, by the way, it's exceptionally rare for the thoracic spine to be hypermobile. Usually it's too stiff. Almost always is too stiff. So when you lack that mobility and rotation, it's going to impact other parts, and other parts have to compensate for that motion. And if you want to, you can stand. And if you're standing and you put your mind's eye, not your actual eye, but your mind's eye on the arch of your right foot, and then you rotate as far as you can to the right, as far as you can to the left, you'll feel the foot reaction take place. Your right foot, when you rotate to the right, will probably arch up. Your right foot, when you rotate to the left, will probably arch down, pronate just a little bit. So again, it's less common because it's farther away from the knee, but everything down the kinetic chain from a stiff thoracic spine has the possibility of compensating all the way down to the foot. So I've had people with foot issues that were thoracic spine problems, believe it or not. Okay. It's not unlike any other body part, though. We need a balance between mobility and stability. The issue with the thoracic spine, though, usually is let's get better mobility in that thoracic spine. And by the way, if you've had knee pain, but you've had also lower back and neck pain, the common denominator for your neck and lower back is the thoracic spine. It's very likely to be a source of your true dysfunction. The bottom line is this, folks: if you've had knee issues and other musculoskeletal issues, and the person you've gone to see or the people you've gone to see never look at what the dynamic kinetic movement system is capable of doing. If you haven't looked to see, is your hip doing what the hip's supposed to do? How about your thoracic spine? What about your ankle and foot? Because we know that if they are not able to do a balance of mobility and stability, other areas have to compensate. They become person A and or person C. And finding and fixing the root movement dysfunction, creating most stability where there's either too much mobility or too much stability, is the key to long-term successful and efficient function. So it's not going to be surprising for you to hear about what successful treatment looks like. If you want your knee pain to be managed long-term, now I don't want to give you the indication that you can eliminate every pain 100%, but if you're dealing with a 7 or 8 out of 10 pain that you've been experiencing for 10 years, what would it be like if you could get on your feet and do stuff and you were only experiencing a 1 or 2 or 3 out of a 10 pain? And you can move a lot better. You can get from point to A to point B with much more efficiency. Your ability to get up and down out of the chair, up and down steps, gets stronger and stronger. If you find and fix the root cause of the issue, you have a much better chance of managing that joint and finding a way to feel and function better. I can't promise you absolute resolution of pain. I can tell you, though, reduction of pain and better function by looking at your entire system is very achievable. Unfortunately, it's not the most common type of treatment. The most common treatments, medications, injections, surgeries, even orthotics and braces, are not truly successful because they do not get to the root of the problem. I'm going to skip through that. I think I've hit that horse a few points, but my encouragement is stop altering the pain, find and fix the root of the issue. So if you want to do that, you got to get to the root of it. And that means looking at you as an individual. What is or what are your specific movement dysfunctions? Is it the hip, the thoracic spine, the ankle, foot? Is it something else? And then we have to recognize that that part is influencing others, other areas, different links in the kinetic chain. So we can't treat the knee in a vacuum. We can't treat it as an independent part because it's a part of a system. We need to have a whole body perspective and then recognize that that knee in most activities has to be able to do its job between gravity and the ground, not on the end of the table lifting the foot up and down. Okay, that process is educational and empowering. What I mean by that is you have to learn the right thing to do at the right time to get the right response. And 2 weeks later, you're probably going to have to do different things. That's why you can't snap your fingers or get a list of the top 3 exercises to make this better, because your needs are going to change and you're going to be empowered to do the right thing at the right time to get that response. We're allowed to see multiple people at the same time. It's called group therapy. We don't do it because that's not individualized. It needs to be one-on-one. Your issues need to be assessed and managed in real time. And I use my hands a lot. There are specific treatments I do to knees. And I sometimes get people on the table and I do manipulative stuff or manual mobilizations. It's all good, right? But another analogy that if any of you are bakers, you'll appreciate this. If you want to bake a really good cake, you have to have the right ingredients. So think about your movement between gravity and the ground as being a good cake. You sometimes have to work on attaining the ingredients. So sometimes you're going to do stuff on a table to make it move a little bit better at the knee. Sometimes you might have to do some leg lifts and lay a foundation. But you need to take each of those ingredients and bring them together in a functional solution when your foot's on the ground, between gravity and the ground. So I like using my hands eventually when people are on their feet and helping create movement in the right timing. It needs to be combined with movement and exercise. So remember, acute trauma gradually gets better over time because it's one stressor that brings it on. The most common kinds of trauma are those slow building ones, cumulative issues. What I just described to you by finding and fixing the root of the problem says, okay, we've gotten above that symptom threshold. Let's take the stress off that tissue. If we can do feel and function better. Now, it won't be a perfect tissue. If you take a picture, you're still going to see stuff. But that tissue is no longer irritated because it's not being asked to do beyond what it was designed to do. That is the key solution. Now, I hope that you found that was informative and somewhat entertaining as well. We solved some problems. We haven't solved all the world's problems. You're not going to remember all this stuff. Okay. Our memories are limited. You still don't know what your problem is. I told you that was going to be the case. And though we like to say knowledge is power, it really is not powerful at all unless we can put it into practice. You have to be able to implement it. So what I'm offering to you tonight for giving me your time is the opportunity to take the next step to learn about your specific needs. And here's what it's going to take. It's 20 minutes with one of our knee pain experts, and they'll ask questions and do a brief screen. And in a short amount of time, you'll quickly understand most likely what your type of knee pain is. You'll understand what are the top problems, the true root causes. And then that person will say, if we want to make this go away, here's what this would look like. And remember, it's not a snap your fingers, do this one thing and it gets better. What does this process look like? I think at the very least, I want you to say, hey, I'm confident we can do something to get some direction that aims at the root of the problem, which should fill you with some hope too. The benefits of this consultation is you're getting to the root of the problem. It's natural. You're avoiding the high-risk procedures and side effects of medications. You're learning how to take control of your own health. And ultimately, I've done this long enough. I would have been pretty timid early in my career, but I've seen enough people over years who've wasted so much time, energy, and money doing things that don't get to the root of the problem. And I am committed to stopping that. I want you to stop wasting time and money and find real solutions that matter and solutions that last. So this time has a value of $150, but I'm happy to say I'm not going to charge you anything. It is a no risk, no obligation time. I want you to at least understand what does your problem look like and what would a solution require of you to do that. Now, I'm not taking your money, so I can't give you a money back guarantee, but I'll tell you, if you do this and you say, that's a waste of my time, tell us, and we'll give $150, the value of that time to your favorite charity. We love helping charities. We do that as much as we can. But I'm really happy and proud to say no one's ever taken us up on this guarantee because it's really informative. It's really helpful. It is not a waste of time. And at the very least, whether you decide to do anything about it or not, at least you know the issue and you have a plan that at some point you may want to choose to do. Or we might say, you know what, I'm not sure this is going to work for you. You might need to do something else. You'll have a consultation summary. You can take that home with you. I will promise you it is not a high pressure sales. We do not do that here. We just want to give people answers. So here's what I'm going to ask of you. You can't, there's a QR code here. You can click on that if you want to. The quickest thing to do, the easiest thing to do, if you want to take advantage of this free screen, is just click on the chat again and say, I'm in, I want it. And then the next thing you need to do is to tell me where you want to do this. So I told you we have 9 clinics from Ames to Des Moines. We have 2 in Ames. We have one in the farthest west part of Des Moines without hitting West Des Moines. We're in Colfax, Newton, Pella, Oskaloosa, Albion, Centerville. If you say I'm in, tell me where you want to be, and we will have someone from one of those clinics give you a call and find a time that works really well for you. I see people coming in here. Linda says she's in. Oh, by the way, I'm seeing some other people who responded earlier. Sorry, I didn't see that. Playing pickleball, says Brenda. I am hearing a lot of that now. That's a great activity. I want you to be able to do that well. And that'd be my goal. Take care of this issue, and you can do all that, because playing pickleball, when done well, is exceptionally healthy and fun to do. I like doing it too. All right, Linda, you're a Blum, so I have a guess where you might be, but you're gonna have to tell me which clinic. Christy says yes in Pella. Oh yeah, there you go, Linda. You're in Pella. There you go. We'll see you, Linda. And Pella. Jean is in. Tell me where you want to be seen, Jean. Kelly says I want to be seen in Newton. Steph says she's in, but no location stuff. So tell me where you want to be seen. Trish says, I won't say your last name, I almost accidentally said that. You want to be seen in the Ames clinic. They'll call you and give the option of our North or our West clinic. Judy says Oskaloosa. Jerry says Pella. Steph says, there you go, Steph. Thank you, Oskaloosa. Aaron, how do you assist patients with their movements when they're hypermobile or have EDS? That is a great question, Aaron. I'm glad you asked it. We've actually just started doing workshops on hypermobility as well. So we actually have clinicians that are very, very knowledgeable on EDS. Very simple response is this. When you have EDS, hypermobility, you really need a well-trained muscular system to respond to that. Now, the key is we can't overload you. We got to do this in a progressive format, but this can be really helpful. People with EDS are going to have more rapid osteoarthritic deterioration unless they can learn to control their mobility and create some balance between mobility and stability. That stability is not going to come from the joints, it's going to come from the muscles. So that's what we focus on. Really good question, Aaron. So yeah, if you want to be seen, that'd be great for you to do a screen to talk about that hypermobility. Jean says Newton, great. Kim's good with Ames, or we're in the west side of Des Moines, but not in West Des Moines, Kim. But they'll call and they'll give you options on that. Bobby says, hello, please. Great. Okay, more of you are writing in now. If you write in, we're going to see this. I told you that I'm going to give you my personal contact information. There it is. That cell phone number gets directly to me. You can call, text, whatever you want to do. If you respond to the emails you've been getting post-registration, that will get to me. They'll forward it to me, but that's my direct inbox right there. That'll get right in my inbox. So that's great if you want to respond that way. One more chat just came through. Denise says she's in. Tell me where you want to be seen, Denise. That would be awesome. Good. I want you to know that you are going to get another email after this. I'm not sure if it's going to come tonight or tomorrow. Ames North, says Natalie. Very good. Denise and Ames as well. Great. Thank you. And on that email, you're going to get, you'll have a link to this session because I did record it. So that's awesome. if you want to do me a favor, there's so many people that are dealing with these issues. If you know other people that are dealing with knee pain, send them that email and have them watch it too. We'd be happy to do a free screen with those people. Carrie, I'm seeing that you're in Des Moines. Denise, Ames North. Great. Thank you. So send it to them. Let them watch it. Like I said before, I've seen way too many people waste so much time, energy, and money on things that don't last. But we want more people to hear about this. I'm getting bolder and bolder in my old age about this. That's great. There's a link to click on there. So if you chose for whatever reason not to sign up for a free screen tonight, you can click on that link to get signed up. If you said I'm in tonight, you do not need to do that. You can just ignore that. And then just know this. I want to be a resource for you, whether it's knee pain, ankle pain, hip pain, whatever. If you have questions, reach out. We're happy to answer questions. At the very least, I want you to feel like you have a knowledgeable friend who understands the human body and how to get to the root of the issue. And I'm happy to have conversations or email exchanges, text exchanges. I'm honored to be asked those questions. I would love to be your the fiduciary of your health. So that's great. Rose in Centerville. Awesome. Rose, Ashley, and company. Would love to see you down there. It's longer than I wanted to be. I'm sorry, I did not keep my promise. It's after 9 o'clock. So I will say this. Thank you. I appreciate your time. You're going to get the recording. Feel free to watch it again and send it off. I'd really appreciate that. And don't hesitate to reach out. Happy to have conversations. So blessed to spend some time with you tonight. Thank you for giving me some of your precious time, and continue to do what you can to help your knee health. All right. We'll talk soon. Bye-bye.